Welcome, my name's John Mackenzie and we're going to talk about urgent chest decompression done 3 ways. The traditional method of identifying the second intercostal space, a new bulletproof method which will work in the very rare opportunities you have to perform this procedure, and then a third way which was used predominantly in the pre-hospital environment. You are going to learn where to place a sharp object into the chest cavity to let gas under pressure out. It's under pressure and causing serious hemodynamic compromise. This most often occurs in the setting of major trauma, but can happen as a result of medical interventions of the airways and rarely spontaneously. So what do you need to do this procedure? It must be indicated, you need the inclination, and you should do it quickly. Ideally you'll have a dwell cath, 90mm long, 12 gauge. If you have a standard cannula, it may be too small and will suggest an alternative spot. You can do this procedure with a scalpel, and we'll talk about that. We do this rarely and in an emergency, in the hospital and pre-hospital setting where there is an obvious or suspected chest trauma and signs and symptoms suggestive of tension pneumothorax and develop hemodynamic compromise. It's a clinical diagnosis. It's more likely when you're positive pressure ventilating. It is indicated in peri-arrest in the trauma setting. There may be penetrating or blunt chest trauma. The patient may be ventilated and this makes it more likely. The symptoms may be chest pain. There may be tachypnea, tachycardia, hypotension, hyperresonance on the affected side and decreased breath sounds on the affected side. None of these are absolutely reliable. It's a combination of all of them. The traditional method is using anatomical landmarks. A perpendicular mid-clavicular line bisects the horizontal line from the angle of Louis or the sternomanubrial junction. This identifies a spot just above the third rib in the second intercostal space. Looking from above, we have our fingers on the two ends of the clavicle. It's pretty clear where the midpoint is. This is the reference which every method uses and demonstrated here on the mock patient. Locate this on yourself or a colleague with permission, of course. So we find the medial head of the clavicle, the lateral head, and the midpoint marks the mid-clavicular line. With just a closer look at the anatomy, we identify the mid-clavicular point, we find the angle of Louis, that's where the second rib inserts into the sternum, and then we go across, and where it bisects sits just above the third rib, so that's in the second intercostal space, and we're above the rib below. We go above the rib below because the blood vessels and nerves run in a groove on the inferior posterior surface of the rib, and this decreases our chance of pranging one of these. Now simply insert the cannula perpendicular to the chest wall. As you go through the soft tissue, it will give way. There is air under pressure, and you will often hear a hiss, or be able to withdraw air if you have a syringe with water attached to it. Both ways are satisfactory. But, you say, what's the foolproof way of getting the right spot? You do it like this. Identify the mid-clavicular point, place 2 fingers snug up against the clavicle, and directly below those 2 fingers is the second intercostal space. Feel for the rib below, and just above that is where you enter. We identify the clavicle, we identify the mid part of the clavicle, and this is the landmark that we use. We place 1 finger immediately below the clavicle, another finger immediately below that, and below that is the second intercostal space, and this is where we place the cannula. As we've said, we already know from some recent work that the traditional spot doesn't work 50% of the time with a standard sized cannula. So if you only have a standard sized cannula, put it somewhere it does work. This spot is the traditional place for the so-called formal chest drain. That's the 5th intercostal space between the mid and anterior axillary lines, shown by the arrow on the skeleton. To find the 5th intercostal space, roll off the medial head of the clavicle onto the second rib and into the second intercostal space. Then the 3rd intercostal space, the 4th and 5th intercostal space. Simply feel your way around to the spot between the mid and anterior axillary lines. Don't just go straight across, you'll be too low. Retrieval doctors working in London and high trauma areas have known for a long time that a cannula is not always the best and safest way to decompress a chest. And in the pre-hospital settings, cannulas can easily be dislodged. They can be dislodged or ineffective in the hospital setting as well. A thoracostomy, or cutting a hole in the chest, is pretty much the same as the start of a formal chest drain, only you need to do it quickly. You identify the fifth intercostal space and mark the incision just anterior to the mid-axillary line. Avoid pectoral muscle and breast tissue. It's about this position marked by the arrow. Clean the area. Identify the landmarks. Fifth intercostal space just anterior to the mid-axillary line. Make an incision. Go above the rib below. After successful decompression, insert a formal chest drain. The cannula, or thoracostomy, is only a temporising measure. You must go on to place a formal chest drain as soon as possible. The standard cannula may be too short 50% of the time if used in the second intercostal space mid-clavicular line. Use the chest drain spot for the standard cannula, or get a long cannula and use that traditional place. In the pre-hospital setting, a thoracostomy works best. If all else fails, put the knife in any setting. In summary, get a big cannula. Use that in the second intercostal space mid-clavicular line. If you don't have one, use the standard cannula in the chest drain spot. Pre-hospitally, cut a hole in the chest drain spot. Consider using this in the hospital and then go on to place a chest drain.
Dad, that looks easy.